Thank you very much. And thanks, Kara. It's always a drag to follow her. Hopefully next year I can be behind someone less dynamic and entertaining. So this is a picture of my kids. The title of the talk is Intracerebral and Spinal Hemorrhages. What do we do with them? This is, in a way, it's a pretty mundane topic, but it's actually something that we as neurosurgeons come across a lot. And then for all of you, the nurses, the scrub techs, the people we work with in the OR, the ICU nurses, the physical therapists, the rehab docs, really everyone that is involved in the acute care of the hospital patient is going to have questions about this, and questions come up quite a lot. And so the point of this talk actually is multifold. It's to target really all of you, and the hope is that all of us walk away with maybe a little bit better understanding. Those are my kids. I wanted to say thank you to the JP&I staff, again, Sagita and Nate for helping me, and then Francis Carr deserves a huge round of applause, but for all the incredible work that she did to put this together. She really did a great job this year, and then of course all the BNA staff, and then the PAs that really are instrumental to us, and then to all the providers here. Thank you very much. Case number 1. So this is a recent case, a 46-year-old male. He came into one of the local hospitals. He had just finished completing his seminary training. He was sitting in church and he developed a severe headache, dizziness, speech difficulty, left-sided weakness. So he has a terrible headache, speech difficulty, dizziness, and left-sided weakness. His past medical history included really high blood pressure, and he never wanted to treat it. He just didn't think it was that important, but he did think it was important to take aspirin because he thought maybe that would help. Anyway, his blood pressure in the ER was 240/160. He had left hemiplegia. He followed some commands on the right when I saw him. Later in the day, he was not when my partner saw him. His eyes were open to stimulation. His gaze was disconjugate. His eyes were going like this. This was his CT scan. Shows a large right-sided hemorrhage. This is an axial CT image of the human brain demonstrating hyperdensity in the right side of the brain. Mike Kiley. What kind of hemorrhage would you call this? Is this a basal ganglia hemorrhage? It looks a lot like a basal ganglia hemorrhage to me.
No.
What kind of hemorrhage is that? It's a right what?
Thalamic.
Yeah, this is a thalamic hemorrhage. This is not a basal ganglia hemorrhage. It's crazy. They're like 1 centimeter apart, but to split hairs, this is a right thalamic hemorrhage. He, in fact, did have meiosis, which is characteristic of thalamic but not basal ganglia hemorrhages. And thalamic hemorrhages classically do rupture into the ventricular system, as this has, and there's blood in his ventricles. Can everyone see that? Let's see here. There it is. It's lighting up. There's no light coming out. Oh, here it is. There you go. So the ventricular system and brain are the really dark areas filled with fluid. The white stuff is blood. This is the primary area where the bleeding started. So, Vicki, I went to see this guy in the ICU, and he'd just rolled from the ER into the ICU, and they loaded him with an anti-epileptic drug in the emergency room because he has this large hemorrhage. Would you have done that?
No way.
Why not? He's got a big bleed in the brain. Why wouldn't you give him Keppra or Dilantin? I'll answer it. But he had been given the drug just in sort of a knee-jerk reaction. Someone, a huge bleed in the brain, they get Keppra or Dilantin. That is wrong. Please remember that. Anyway, so intracerebral hemorrhages, they account for about 10% of strokes. in the Boulder area. We'll see about 60 of these in our county or in our catchment area every year. The 30-day mortality is remarkably high. It's on the order of 40 to 50%. And look at that other little fact there. Only 20% of those who have an intracerebral hemorrhage will be independent at 6 months. It's devastating. This is not like your standard stroke. And the economic cost is huge. This is a really busy slide, but let's just focus on really some important things. You can't change your age, you can't change your gender, you can't change your race or ethnicity, but what are the things that you can do to help prevent yourself from having one of these? There are really 3 things. Don't smoke, don't drink so much, and treat your high blood pressure. So there are 3 things that you can do to help save yourself from this terrible fate, because it's terrible. This guy actually was a friend of a friend. I didn't know that when I went to see him. Types of intracerebral hemorrhage. The types aren't terribly important, but here's a huge hemorrhage with extension in the ventricular system. This is actually a thalamic hemorrhage. This is a basal ganglia hemorrhage. I know you're looking at those, they look like the same thing, but maybe I'll be able to point out the difference. So, neurosurgeons love anatomy, and there is a difference. The putamental hemorrhages, this is a basal ganglia hemorrhage. This is called the putamen. These blood vessels that perfuse this part of the brain are completely different from the ones that perfuse the thalamus. This area bleeds much more often than the thalamus. So number 1 is a putamental hemorrhage, tiny part of the brain, but really has a predilection to bleeding. Lobar hemorrhages occur second most frequently, but we're talking about a huge area of the brain, the frontal lobe, the parietal lobe, the occipital lobe, the temporal lobe. I mean, the lobar hemorrhages encompass the entire rest of the brain. This one little area bleeds most frequently, this second most frequently, even though it's a huge part of the brain, and then the thalamus is third most common, and there's a reason for that. The causes include arterial hypertension, little microaneurysms. I was going to go over this Netter diagram because it totally confuses even neurosurgeons. We don't really remember what the lentiform nucleus is, or the striatum, or the basal ganglia. But for those of you who are sort of anatomy purists, this is the human thalamus. It is not part of the basal ganglia. Okay, so this is not basal ganglia. The lentiform nucleus is the lens-shaped nucleus here or here. These guys right here, the lentiform nucleus. The lentiform nucleus is composed of the putamen, and Beasley's probably the only one in the audience that really knows this, or Dr. Giroux, if she's still here. But this is globus pallidus externa, GPE. This is GPI. So putamen, GPE, GPI, that is the lentiform nucleus. The striatum is the combination of the caudate and the putamen. So the basal ganglia is the combination of the striatum and the lentiform nucleus. And in fact, the head of the caudate connects to the putamen. They're contiguous. The cell bodies that comprise them in 3 dimensions are contiguous. This right here, is this part of the basal ganglia technically? This is the head of the caudate, or not the head of the caudate, but this is the tail of the caudate right there. Yes, this is still part of the basal ganglia. This is not. That's the thalamus. Anyway. The reason why you bleed a lot into the basal ganglia is it is fed off of the lenticulostriate vessels. So all of this talk about the lentiform nucleus and stuff, Mason probably eats this up because he's our cerebrovascular specialist, but this is the lentiform nucleus, this is the striatum, and guess what? It's perfused by the lenticulostriate arteries, like neuroanatomy is super simple. And it comes off of the middle cerebral artery. The middle cerebral artery is a huge bore blood vessel This is a completely unique aspect in the human body where you have terminal end arterioles coming off a huge blood vessel. Look at these blood vessels out here. How do you get there? Well, it branches and branches and branches and branches and branches and branches, and then voila, you get a terminal artery. So the entire brain is perfused with these small blood vessels that come off of branch. The basal ganglia doesn't do that. You've got this huge artery, tons of pressure perfusing the basal ganglia. This is why humans bleed into their basal ganglia. It's dangerous. I don't know why we're set up that way, but these guys are born to bleed. You say, well, why are you making such a big deal out of this? Well, the basal ganglia is most common, and there's a reason for it. These blood vessels here, I was pointing this out with Greg because it was like a perfect picture, but these guys are the thalamo-geniculate vessels. They perfuse the geniculate bodies and the thalamus. They don't come off the middle cerebral here. They come off the posterior cerebral. It's a much smaller vessel. It's like half the size of your MCA. It's a much smaller vessel, technically a little bit lower pressure, but also very prone to bleeding, but slightly smaller apparent vessel, so this bleeds less. At least that's my theory. Anyway, huge AVM here. We need to move on because I'm going to take my whole talk in this part. So people present with altered consciousness, headaches, convulsions, nausea and vomiting, and they have focal neurologic deficits. So in your handout, there'll be a list of things that these cause, but putaminal hemorrhages, you don't have to remember all this. They get contralateral weakness. They have some gaze problems. Not very difficult to understand. Thalamus gets, this will be interesting for the PAs when y'all go to see your next thalamic hemorrhage. Look for meiosis. The mechanism of that is that the sympathetic fibers that flow to your eyes, the sympathetics make your eyes dilate. So why would a thalamic hemorrhage cause pupillary constriction, whereas a putaminal hemorrhage wouldn't? Well, the sympathetic fibers flow out of the hypothalamus, through this area, back to the brainstem, down the brainstem, down in the cervical cord, out through the stellate ganglion, isn't that what it's called, onto the carotid artery, and then back up to the eyes. So if you interrupt those things coming out of the hypothalamus, then you get the parasympathetic response out of the Edinger-Westphal nucleus, which is located at the tectum, and those still work. So the third nerve's working, causes constriction. The sympathetic fibers are interrupted, you get meiosis. It's just sort of fascinating, but thalamic hemorrhages can cause that. Caudate nucleus hemorrhages cause contralateral hemiparesis. Brainstem hemorrhages, the only thing to walk away with this, also meiosis, because it's interrupting the same sympathetic fibers as they descend through your brainstem. They can't get to the eye. The other thing sort of cool is ocular bobbing. Their eyes will go down and then snap up, and it's called ocular bobbing. I don't know if Alan Zacharias is here, but he could probably explain it to us. Anyway, that's characteristic of both brainstem and cerebellar hemorrhages. This is a big cerebellar hemorrhage. They get ipsilateral sensory loss. Let's keep moving. Lobar hemorrhages. The only thing for y'all to look at when you examine a patient with a lobar hemorrhage, pretty common. It's usually more of a parietal lobe thing, but they get abulia. And Zacharias mentioned this in his talk. Strokes, lobar strokes can get this. You say, what is abulia? Does it mean you stick out your tongue or can't stick out your tongue? No, it's just apathy. It's a fancy word for apathy. It's, I don't know, when I first read it, I was thinking, gosh, it has to do something with the tongue or something. But anyway, it's apathy. The worst form of it is akinetic mutism. This is where someone really doesn't care that they have a hemorrhage, and they sit there, they won't talk, and they just sit there, and they just look into space. But they're there, they can hear you. But that's the worst form of abulia. It's called akinetic mutism. It's severe apathy. They really don't care. Imaging characteristics, I mean, you don't really need to know these. I mean, only the guys studying for their boards need to know what intracellular and extracellular met hemoglobin looks like on MRI and the radiologists. It's interesting, but we don't have time. Management principles, reduce ICP, reduce hematoma expansion. So guidelines for the management. So much of this talk comes from the guidelines that were published in 2010. So there is a guidelines written for how do we manage these patients. Really, from this slide, all you got to know is get an image. It's almost always a CT scan and you see blood. Think about CT angiography and the other modalities. If it's a weird-looking hemorrhage, look for some other things like AVMs. Look for, beware of sinus thrombosis because that can fool you. Treatment with sinus thrombosis is completely different. If they're really coagulopathic, then reverse them and reverse them properly. That's all. There's class 1 evidence for that. If the INR is elevated due to oral anticoagulants, then go ahead and give them some vitamin K and replace their factors. We're moving now to more PCCs, getting away from FFP, although we haven't really made that transition yet at our hospitals. It's starting to happen as we speak. And the reason for that is PCCs seem to do sort of the same thing but have fewer complications. You're giving a synthetic drug to replace their clotting factors as opposed to transfusing them a human serum. A few years ago, we wanted to give factor 7 to all these patients. It's really gone now. No one does that. It's not a good idea. Don't just give people factor 7. You could give it if you think they're going to die, but you've got to give some other factors. So you almost always combine factor 7 with a PCC or an FFP or something. It can't reverse a warfarin bleed alone. There was this push a few years ago, and we talked about it among the surgeons. Gosh, should we start giving normal people factor 7? Well, it can stop the bleeding in the brain, but next thing you know, they start clotting off the other blood vessels of their body, which is bad, like their left anterior descending, and their heart dies. So don't do it. Anyway, this is something we do all the time. It's only class 2B evidence, according to the guidelines, and it's totally investigational, but yet, like every one of us will say, well, give them some platelets if they're on aspirin. It's totally investigational. You don't have to do it. No one has any idea if it does any good, but all of us do it. I mean, it makes us feel better that we're doing something for such a terrible problem, and we can't really help them anyway. So, should they have stockings? Yes, put stockings on them. When do you anticoagulate them? Class 2B data. Start thinking about it as early as day 1. If the hematoma is stable, you could start at the first day, or you could start at the 4th day. Certainly by the 4th day, you need to be giving very serious consideration to a hemiplegic patient to putting them on some kind of pharmacologic DVT prophylaxis. This side's so busy, just lower their blood pressure, for God's sake. Because that works. Lower the blood pressure. We already do that. Everyone has that part figured out. It's not that controversial. Glucose, make them normoglycemic. Here you go. Prophylactic anti-epileptic drugs should not be used. Now, this statement is a class 3 statement, but it is a positive negative statement saying don't give anti-epileptic drugs prophylactically. What if they're in status in the ER and they have a hemorrhage? Well, you're going to give them a drug. For God's sake, they're seizing. So give them a drug, but they almost never do. And so why give them a super expensive drug like Keppra when it's not indicated prophylactically? There's just no reason to do that, but yet we do it all the time. Anyway, Icp monitoring. Yeah, if they're comatose, you can go ahead and think about it. It's only class 2 evidence. It's reasonable if there's a decreased level of consciousness, 2A even. And then intraventricular hemorrhage, you can put TPA in their ventricle, but it's still sort of investigational. If you want to get the blood out, you can do it, but it's not a standard of care by any stretch. This is one of the big ones. So should we take it out? Everyone, these people come with these huge hemorrhage, and everyone looks at you like, why aren't you operating on this? Because there's really not a lot of data to suggest that we should. That's why. In 2005, the STITCH study came out, STITCH 1, the surgical trial of intracerebral hemorrhage. It was 1,000 patients, 1,033, and there's really no difference between those randomized to early surgery and those treated medically in their outcomes, and all of them did crappy. So the positive outcome was 26% in the surgery group, 24% in the conservative group. There was no statistical difference, and so we walked away from STITCH 1 thinking you shouldn't really do surgery, but the trial, of course, got criticized, as all trials do. And the problem with STITCH is that their outcomes were so terrible that it seems that maybe they were randomizing patients that were half dead anyway, and so why let those patients participate in the trial because they're already so far gone. So then STITCH 2 got published in August of this year, so it's really new. And that was 600 patients, 300 on each arm roughly, and those that had early surgery in STITCH 2 did better than those who were treated medically. So there's a trend towards having a little bit better outcome. The difference was 59% versus 62%. But it was barely statistically significant. So you take him to the OR, do a craniotomy, take his blood clot out, and yeah, the data suggests maybe slightly better with surgery, and that was only for hemorrhages within a centimeter of the cortical surface. So these huge, deep thalamic hemorrhages, like the one I just showed, it wouldn't apply. We're talking about hemorrhages that you could reach just barely under the surface. Those patients did a little bit better. The difference was 59% versus 62%. So, yeah, maybe it's a little better, but that's not really strong evidence that surgeons should be jumping on top of these. It's a case-by-case basis. It takes judgment. But this is why, the nurses will look at us like, well, are you going to operate? And our fellow physicians, are you going to operate? And we're trying to, what neurosurgeons are trying to do is sort this out. Like, gosh, I don't know that I should. We're taking into account everything about the individual patient. But there's not a lot of evidence that surgery is great. The one thing that does work, if their cerebellum is bled and they're becoming comatose, yes, you should operate on that. Class 1 evidence. Surgery is better. So we can go take the blood out of their cerebellum. That's totally different than a basal ganglia or thalamic hemorrhage. So please, neurosurgeons, operate on the large cerebellar hemorrhage. We already do. Don't go around and just put a ventric in. Look at this statement. Ventricular drainage alone is not recommended for a cerebellar hemorrhage. Because if they're crumping from a cerebellar hemorrhage, it's from pressure on the brainstem. Don't just drain their hydrocephalus. You can. There would be circumstances where you could do that. But as a routine thing, you need to go ahead and start thinking about just going straight to the OR. These studies talked about early treatment. By the way, the STITCH 2 trial was within 48 hours. The studies do suggest ultra-early treatment for these is bad. So taking someone to the OR at 1 in the morning with a large hemorrhage in the brain is controversial. The ultra-early surgery patients did worse. And you say, what's the mechanism for doing worse with ultra-early surgery? It turns out that when you operate on these patients that have these big hemorrhages, we suck the blood out, and then the neurosurgeons will all tell you this, and the PAs says, when we're done, there's like this spaghetti, the blood vessels in the wall of the cavity are bleeding. They're just all bleeding, and so we go coagulate all these, so you end up stroking a bigger part of their brain. I mean, it's like spaghetti, like snakes from Indiana Jones, the first movie, whichever it's called, Raiders of the Lost Ark. You know, but isn't that what it looks like, Kara? They're like wiggling like this, and they're just squirting blood into the cavity. And so the ultra early patients didn't do quite so well. So if your neurosurgeon on call has a big hemorrhage, it comes within a centimeter, and the patient doesn't look like they're acutely dying right then, you can make an argument for saying, you know what, I'm gonna do this in the morning. But the neurosurgeon may say, I want to do it now, and they have a reason for it. So it's a matter of debate. But the timing of surgery, it's usually better to wait like overnight. And what happens is the blood clot organizes, those vessels calm down. It makes it a little more straightforward. Am I running out of time? Yeah, there was all this excitement again over the last decade about like making a little tiny hole, running a tube in, and then taking things out minimally invasively. There's no data yet really to support this conclusively. And this was that other statement. No clear evidence indicates ultra-early removal of supratentorial ICH improves functional outcome or mortality. Very early craniotomy may be harmful. So it's class 3, but just keep that in mind. Case number 2. 70-year-old male attorney from Seattle, abrupt onset of left-sided weakness the day after his mother's funeral. He's down here, went to his mom's funeral, and the next day he develops left-sided weakness. He has sort of a bad past medical history. Oh, I'm off. I'm sorry. There's the history. Here's the some additional relevant data. He does have high blood pressure. He takes drugs for it. He's had strokes, coronary artery disease, and whatever OSA stands for. That's right. Anyway, I was just going to see if someone knew it. That's good. Anyway, blood pressure systolics were in the 180s. He had left hemiparesis, left lower extremity plegia. He did follow commands. This was his scan. Who was I want to ask? I'm going to ask Sarah. What kind of hemorrhage is this, Sarah?
It's like a hemorrhage of the basal ganglia.
This is a right basal ganglia hemorrhage. Here's the thalamus here. That's basal ganglia. And look, it's lens-shaped. That's like amazing. It's the lentiform nucleus. And this is lens-shaped. That's really amazing. Okay, I've got another question. Christy, 2 days later, he's doing about the same. He still doesn't really move his left arm. They get a scan, and this is surrounded by edema. Why don't you put him on steroids? Would you put him on steroids?
No.
But it's got edema around it, and he still can't move his arm.
It hasn't been shown effective for this type of swelling, more for vasogenic.
That is correct. What kind of so that was very good. What kind of edema?
Can you repeat what she said, because people can't hear you?
So there's no reason to put this patient on steroids. They do not help. And they set the patient up for an infection and all kinds of other complications. Don't put them on steroids. The edema surrounding a hemorrhage is cytotoxic edema. It is not vasogenic. Steroids do nothing but hurt the patient. Don't do it. Quit doing it. Quit asking us. Okay. I mean, do you want them on steroids? You'll show up. Guess what? I saw this gentleman. I signed off immediately, said, you don't need me. I'm a neurosurgeon. You have a small hemorrhage in brain that will resolve. I had gotten a follow-up scan a few hours later, stable. I signed off. Guess what? After I left, 2 or 3 days later, he was put on steroids by his primary team. Because guess what? His CT scan showed edema. They were wrong. Anyway. ARS. Oh yeah, so this is my first question. And I'm going to play my own music. Because Okay. This is sort of an inside joke. I don't know if y'all can hear that. What are the 3 risk factors for ICH, and are they modifiable by the patient? Oh, that's good. C, D, and E. That's good. Okay, great. So those 3 risk factors. So next question. What is the most common location of spontaneous ICH? Lobar or cortical? That's the same thing. I guess O. The putamen, which is the same as the basal ganglia. The brainstem, the thalamus, or the cerebellum. It's just a joke. I'm not really trying to play it. Great. Good job. Perfect. I like easy questions too. I think they're useful. Okay, here's a good one. Pharmacologic DVT prophylaxis is contraindicated in patients with intracerebral hemorrhage. True? False? Or false, you can start DVT prophylaxis 8 days later. What's the answer? That is correct. False is the answer. It's not contraindicated. So maybe we learned something from that, because a lot of people think, oh, there's blood in the brain, we can't give Lovenox. That's not true. Remember, the data suggests you can start thinking about it as early as day 1. But it's a case-by-case basis. The hematoma needs to be stable. Okay. Question number 4. Anti-epileptic drugs should be given to all patients with spontaneous ICH, especially those with lobar hemorrhages. So where would a hemorrhage come from? Of all the hemorrhages, which one's most likely to cause a seizure? It would be a lobar hemorrhage. So shouldn't you give someone with a lobar hemorrhage an anti-epileptic drug prophylactically? What's the answer? Oh, no, I'm letting him do it now because this joke's done. It wasn't that good. It's hard this late in the afternoon keeping you guys awake. Yes, good. God, I love it. Y'all are smart. Okay, but it's funny, y'all just got that right, but every patient comes to the hospital gets it wrong. And anyway, ultra-early removal of supratentorial hemorrhages should be considered to improve outcome. Should you do it? In general, the answer is B, false. Good. Good. You can consider it. So true is not totally wrong, but that would be a case-by-case basis. Some neurosurgeons would do it when they absolutely have to. Okay, management principle summaries. This is just a summary of the major points. Oops. I have more talk to go. He has to unblock me. Oh. I have a lot more talk, but I'm done. Okay.